Can you hear me? Elizabeth, can you hear?
Yes.
Okay. So Dr. Shifana has come in?
Yes, sir.
Shifana Varma, sir.
Good evening, Dr. Shifana.
Good evening, sir.
Yeah. So you will present your case. Inhale, exhale, and relax and present your case. Okay?
Okay, sir.
Right. Okay, let us listen to you.
Good evening, everyone. I'm presenting the case of Master Leona, who is a 15-year-old male studying in 11th standard, hailing from Thiruvananthapuram. He presented with complaints of fever since 12 days, pain and swelling around the left eye since 11 days. History of present illness. Patient was apparently normal 12 days back when he developed fever, which was sudden in onset, high grade, associated with headache, running nose, and cough. Fever lasted for 2 days and which got subsided after taking medication from a local hospital. Next day morning, he developed pain and diffuse swelling around the left eye. Pain was sudden in onset, continuous, severe, and throbbing type, which was aggravated by ocular movements. Periorbital swelling was acute in onset and severe enough so that the patient could not open his eyes, and the skin around the eye was red and shiny as per the mother. On attempted opening of the eye, patient noticed mild blurring of vision and double vision. Double vision was present only when both eyes were open and disappears on closing either eyes. No history of itching, discharge, or colored halos. History of blunt trauma to the left eye with football while playing at school, which was a high velocity injury 20 days back. He did not have any ocular complaints immediately after that, so he did not seek any treatment. History of recurrent episodes of upper respiratory infection in the past. No history of insect bite, no history of earache or discharge, no history of dental caries or dental infection, no history of abdominal pain or dysuria, no history of altered mental status, neck stiffness, nausea or vomiting, no history of intolerance to cold or heat, fatigue, excessive sweating, diarrhea, constipation or palpitation, no history of epistaxis, no history of loss of weight or loss of appetite, no history of swellings elsewhere in the body. Coming to past history, history of tonsillectomy 4 years back, no history of any systemic illness, no history of any chronic drug intake, and no history of any drug allergies. Family history, no family history of thyroid disease, malignancy, or connective tissue diseases. Personal history, he follows a non-veg diet, sleep and appetite are normal, no alteration in bowel or bladder habits, no history of any addictions. General physical examination, patient is conscious and cooperative, well-oriented to time, place, and person, well-built and nourished, no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or bilateral pedal edema noted, skin, hair, and nails were normal, skull and spine was normal. Vitals, pulse rate was 80 per minute, regular rhythm, normal volume, character and condition of vessel wall. Blood pressure was 120 over 80 millimeters of mercury, recorded from the right arm in sitting position. He was afebrile to touch. Respiratory rate was 14 per minute. Systemic examination, no thyroid swelling was palpable. Central nervous system, higher mental functions were normal. Sensory and motor systems were within normal limits. Cranial nerves were normal. No focal neurological deficits elicited. Cardiovascular system, S1 and S2 were heard normal. No murmurs were noted. Respiratory system, nasal cavity was normal. Deviated nasal septum noted to the right side. No sinus tenderness noted. Normal vesicular breath sounds heard with air entry bilaterally equal. No added sounds were noted. Gastrointestinal system, oral cavity was normal, no dental caries noted. Per abdomen was soft, non-tender, no organomegaly noted, and bowel sounds were heard. Coming to the ocular examination, inspection, head posture was normal. Hirschberg test showed a less than 15-degree esotropia. No facial asymmetry, nystagmus or lag of ophthalmos noted. Ptosis was noted in the left eye. Periorbital region showed mild periorbital edema and with no erythema. Fullness of the superior sulcus was noted. No visible pulsations or dilated blood vessels noted. No change of the swelling noted during Valsalva maneuver or bending forward. No thyroid eye signs were noted. Coming to the extraocular motility, there was -1 reductions. There was -1 restriction on elevation, and on versions there was -1 restriction on dextro elevation and levo elevation. Coming to palpation, there was no local rise of temperature or tenderness. Orbital margins were intact, able to insinuate the little finger between the globe and the orbital margin. No distinct swelling was palpated. Skin over the area was normal. No palpable pulsations or thrills were noted. No enlarged regional lymph nodes palpated, no resistance to retropulsion of globe, no supraorbital or infraorbital anesthesia. Auscultation, there was no buoy heard. Coming to measurements on exophthalmometry with Hertel exophthalmometry with base at 103, right eye was 16 mm and left eye was 19 mm with 2 mm horizontal and vertical dystopia noted. Ptosis evaluation in the right eye, MRD1 was 7 mm and MRD2 was 8 mm with a total vertical aperture, palpable aperture of 15 mm. Margin free distance was 11 mm. LPS function was normal. No lag of thalamus noted. Good Bell's phenomenon was noted. Jaw winging was absent. In the left eye, MRD1 was 0 mm, MRD2 8 mm, vertical palpable aperture of 8 mm. Margin crease distance was 10 mm. LPS function was fair. No lag of thalamus noted. Good Bell's phenomenon and absent jaw winging was seen in the left eye. Coming to the examination of the since the patient presented complaints in the left eye, I am presenting the left eye first. Distant vision was 6/6, near vision was N6, color vision was normal, and field of vision by confrontation was normal. Eyebrows were normal. Lids, ptosis was present. Lid margins and eyelashes were normal. No blepharitis or meibomitis noted. Adnexa, lacrimal gland area and lacrimal sac area and punctum were normal. Regurgitation test was negative. Conjunctiva, mild conjunctival congestion was present. No chemosis or discharge noted. No dilated episcleral vessels noted. Sclera was normal. Cornea was normal in size, shape, and transparency. Corneal sensation was normal. Anterior chamber, no cells or flare noted. Van Herrick's grade 4. Iris, normal color and pattern. No iris nodules noted. Pupil was 3 mm, round, central, direct, and consensual light reflex by brisk. No RIPD was noted. Lens was clear. IOP with Goldman applanation tonometry at 4 p.m. on 3rd August was 16 mm mercury in primary gaze and 18 mm mercury in upgaze. Distant direct ophthalmoscopy, red glow was present. Slit lamp biomicroscopy with 90D lens. Media was clear. A normal sized disc with vertical cup disc ratio of 0.3. Neuroretinal rim was even and pink. Disc margins were normal. Peripapillary region was normal. Foveal reflex was present. Arteriovenous ratio of 2:3. Indirect ophthalmoscopy with 20D lens. Background retina was within normal limits. Right eye examination was within normal limits. Summary. 15-year-old male with history of recurrent episodes of upper respiratory infection in the past and a history of blunt trauma to the left eye with football 20 days back, presented with complaints of fever since 12 days and pain and swelling around the left eye since 11 days. General physical examination and systemic examinations were within normal limits. On ocular examination, mild periorbital edema was noted with fullness of the superior sulcus. Proctometry showed a 3 mm difference between the left and right eye with a 2 mm horizontal and vertical dystopia. Severe mechanical ptosis was noted in the left eye. Mild limitation of extraocular motility was noted in dextro and levo elevation in the left eye. Visual acuity of the left eye was 6/6. Mild conjunctival congestion was present. Rest of the anterior segment examination was within normal limits. Pupil was brisk. No RIPD noted. Fundus examination was within normal limits. Right eye examination was within normal limits. Coming to the provisional diagnosis, abaxial down and in proptosis with severe mechanical ptosis left eye. No features of exposure keratopathy or optic nerve compression. Differential diagnosis. Orbital cellulitis secondary to infected hematoma post-trauma, idiopathic orbital inflammation, dacryoadenitis, lymphoma, leukemia, orbital myositis, and preseptal cellulitis.
I'm sorry. Yeah. Shifana,
Sir.
come to the third slide, presenting complaints, and you have presented really well, Dr. Shifana.
Thank you, sir.
Very nice. Now I want all the PGs to switch on their videos. And keep your microphone muted. So we have a male at 15 years, a boy. We'll come to the third slide. Next one. Yeah, fever and pain. Okay. Now what I want is, what are the, if you have pain in the orbit and an orbital disease with pain, what are the possibilities you are thinking?
Orbital cellulitis,
Very nice.
idiopathic orbital inflammation, in carcinomas.
Very nice. Malignancies, particularly malignant lacrimal gland tumors, where there is perineural invasion. So we have pain as a hormone. Yeah. Then metastatic malignancies, carcinomas can also have pain in the organ. Okay. And if what can happen when you give a retrobulbar block for cataract cells?
Retrobulbar hemorrhage.
Correct. So that can also a hemorrhage, a sudden increase in the contents of the orbit can also produce pain in the, isn't it? If you have a trauma and you have a huge hematoma, that can also produce pain. If you have edema, also following trauma, which is suddenly increasing, means it can produce pain. A sudden expansion is always creating pain, isn't it? Whereas what is the pain character in thyroid eye disease? Is there pain at all, or is there no pain? A dull ache, a dull deep orbital ache. So that is one thing. Okay, come to the next slide. So after listening to your history, normal, and then suddenly also high grade with headache, then next day morning you develop pain. And okay. What are the possibilities you are entertaining?
Fever with swelling can be orbital cellulitis.
Very nice. Then
Preseptal cellulitis.
Very good. Yes. Then,
idiopathic orbital inflammation.
Yeah, idiopathic orbital inflammation usually doesn't present with fever. Usually no. Fever is not usually there, but pain is a hallmark of non-specific orbital inflammatory disease. That is the pseudotumor orbital, isn't it? Then, what else? You have an upper respiratory and a proptosis. We have not come to that, but still a painful orbit. Any malformations can present like that?
AV malformation.
No. Apart from that, a sudden onset after a respiratory infection.
Lymphangio.
Okay. Very nice. Lymphangio is also called, we know, lymphatic malformation. That is the current name of lymphangio. We used to call it lymphangioma, but now it is veno-lymphatic malformation. Why should there be pain in veno-lymphatic malformation? Usually it is a younger child, not 14 years, slightly younger child. You can have a history where the mother says, every time there is a respiratory infection, the eye protrudes a bit. That is a classical history of a veno-lymphatic malformation. But when will it present with pain and redness?
Following trauma can...
When there is a bleed into this, when there is a bleed. Veno-lymphatic malformations are known for getting repeated bleeding into the lesion. And that produces an acute proptosis with pain. So at this point, you can think of that also, no? If it is an older patient, if you have got upper respiratory, lower respiratory, sinus involvement, renal involvement, and all that, 40 to 50 years, presenting with a painful proptosis. an older patient, upper respiratory, lower respiratory, then renal issues, scleritis, sclerokeratitis. What is the disease? Vagus granulomatosis. Okay, that is one where you have this. It's a necrotizing vasculitis. Small and medium vessels are undergo necrotizing vasculitis. So there you have this upper respiratory infection. You will have lower respiratory infection. You have renal issues and all that. Not related to this particular patient, of course. Yeah. Why did you ask for colored halo syndrome?
Discharge can cause.
Very good. Discharge can produce color halos. Tell me two other conditions which produce color halos. Dr. Soumya. Dr. Soumya, one PG is there. Hello, Dr. Soumya.
Yes, sir.
And yeah, tell me. What are the other conditions which can produce colored halos?
Acute congestive glaucoma and
Very nice. Then
full and conjunctivitis.
Conjunctivitis, then
And
what else? The most
glaucoma, sir.
no, acute congestive glaucoma you have said. You have told about acute
cataracts,
pupil. Pardon?
Cataracts, sir.
Yeah, the immature senile cataract, isn't it?
Cataract.
Okay. Yes, Shifana. So can a patient present with an acute red eye, with pain, nausea, vomiting, if he had an upper respiratory, if the patient is at 60 years, female, presenting with acute onset, pain, redness, nausea, vomiting, blurring of vision, following an upper respiratory infection, which drugs can incite or trigger an acute angle closure glaucoma in any patient, in an older patient? Oh, pardon? Topiramate has an entirely different mechanism. You don't give it in an upper respiratory infection. See, remember that most of the decongestants and the cold remedies and the antihistaminics that we give, they all have an anticholinergic effect. So they may just go over the counter, they will buy and simply consume and can come back with a predisposed patient can come back with an acute attack. Okay. Now, next slide, please. History of blunt trauma to the left eye with football while playing at school 20 days back. No ocular complaints. Now, what are the possibilities at this point? Trauma to the eye with a football. And you are saying it's a high velocity injury, isn't it? So, what are the possibilities you are entertaining at this point?
Orbital hemorrhage, orbital emphysema.
Orbital hemorrhage, very nice. You said orbital emphysema. Excellent. Orbital emphysema, very nice. And what else can happen?
Bone fractures.
Fracture even involving the rim or without involving the rim. What fracture is that? A ball has come and hit like this onto the anterior orbital rim.
Rim, including the rim fracture.
Rim can be fractured, yes. But what is the one that we commonly see? When the orbit is very nice. Yes. Blowout fracture can happen. Blowout fracture, which wall is involved, Shifana?
Inferior floor.
Floor. Next.
Floor.
Which other floor can be involved? Which other wall can be involved?
Medial wall.
Very nice. Which is the thinnest wall of the orbit?
Medial wall.
Very nice. Then which is most common? Which wall is most commonly involved? The inferior, the floor. The floor fractures are more common, isn't it? And that is why is that?
Blowout fracture.
Why blowout fracture is more common inferiorly, even though the thinnest wall is the medial death marks. Why is that?
Sinus, maxillaries.
No. Because in the floor, actually, there is nothing else below that floor. Whereas in an ethmoidal ethmoidal bone, we have air pockets actually, which buttresses. It's like your packing material that we have packed things, packing material with air pockets. So they can withstand more impact than the floor, which is thin. Even though it is thin, it is not as thin as the medial bone. But that is the reason why we have more common blood fractures in the floor. So blood fracture is a possibility here, isn't it?
Yes.
It's also a possibility. So it can be a bleed, then and then the eyeball can get damaged, isn't it? The eyeball can be damaged. At this point, you have not examined, so the eyeball can be damaged, isn't it?
Damaged.
Then, okay. And what is orbital emphysema? You said orbital emphysema. What is that?
Air can escape into the orbit
From where?
in a case of fracture. Sinus, surrounding sinus.
So any communication between the sinuses and the orbit, isn't it?
Yes.
Can produce orbital emphysema, isn't it?
Yes.
Then, what is the other condition where you get gas in the orbit, madam? Chipana? Okay, we'll come to that subsequently. If there is a running nose, if this is not this upper respiratory, I'm saying after the injury, patient has a running nose. What is the possibility we'll think in terms of you have to rule
out? Sinus infections.
Any other PG would like to answer that question? A blunt from, pardon?
Cribriform plate.
Very nice. Very nice, Dr. Anchana. Okay, very nice. So you can get a fracture of the cribriform plate and you can have a leak of CSF. So whenever you have a running nose without much of constitutional finding features, you have to think in terms of a CSF leak. That is also very important, isn't it? So it has got a very close relationship to the orbit. The medial wall of the orbit has how many bones, Dr. Shifana, tell me?
Medial wall is formed by ethmoid,
Anteriorly
by
the frontal process of the
frontal process of maxilla.
Very good, maxilla, and behind that we have, which is a bone which we break. Yeah, very nice. The lacrimal bone, very good. That is the bond that we break in DCR, isn't it? Which are the two bonds that we break in DCR? What is DCR, Shifana? Dacryo, cysto, rhinos, isn't it? Yeah. Which bonds are we breaking there? We'll break the lacrimal bone as well as the frontal process of the maxilla. Okay. To create an opening into which part of the nose? In a DCR, where are we opening into in a DCR?
Nice.
Middle meatus.
Yeah, in front of the middle meatus of the nose. Very good. And the other bones, what are the other two bones? Behind that we have the ethmoid, and behind that we have
body of sphenoid.
Okay, bone out of the lesser wing of the sphenoid. Very nice. So that, and between the ethmoid and the frontal, we have the frontoethmoidal suture, isn't it? So generally, whenever we are touching the medial wall surgically, we should never go beyond this frontoethmoidal suture. You should never go above, because then you can go into and break the cribriform plate. Understood? Yeah. Okay, then. So you have told about earache or discharge. Why is that? Why do you want that history?
Spread of infection from.
Very nice. So dental caries once again. Dental caries, you also have to remember that you can get anaerobic infections are more common after dental caries. Okay. When it is the source of infection is dental caries, chance of anaerobic infection will be there. And if there is an abscess in the orbit, you take a CT, you will see gas in the axis. Gas. Presence of gas, apart from orbital emphysema, it indicates anaerobic infection. Okay. Why history of abdominal pain or dysuria?
Systemic spread
Systemic
of
spread
infection.
from urinary tract infection. That one very nice, very nice. Okay. Okay, next slide. So why intolerance to cold in this
Thyroid,
situation? What thyroid is that?
hypothyroid.
Hypothyroid, and okay, that and all you have said. Saying diarrhea, diarrhea in
Hypothyroidism.
very nice. Palpitation in
Hypothyroidism.
very good, very nice. Okay, loss of weight. Okay, those things are fine. What systemic illnesses are you want to rule out? Bleeding disorders. Next slide. Which bleeding disorder? Generalized bleeding disorders? Hemophilia? Is that what you're thinking? Why is that? Next slide. Next slide. The next. No, past history. Go to past history. Yeah. What systemic illness are you ruling out?
Type 1 diabetes,
Yes.
bleeding disorders, hemophilia.
Yes. What about sickle cell anemia you want to consider? Yes.
Yes.
Yeah. It can produce occlusive vasculitis of bones of the orbit, isn't it? It can produce
Yes.
periostal hematoma. Bleed into the orbit can happen. If you are practicing in Africa, means every other patient who comes with a trauma, they will do test for sickling, isn't it? Yeah. And we also have some population who have sickle cell anemia, isn't it?
Yes.
And history of malignancy, isn't it? That also we have to look at. Yeah. What chronic drug intake? What is the relevance?
Systemic steroids can cause
Very good.
immunosuppression.
Very nice. Any drug taken nasally?
Inhaled corticosteroids.
Very nice. Inhaled corticosteroids predisposed to fungal infections of the nose, isn't it? Yeah.
Yes.
What about if the person is a drug addict?
Again.
Yeah, cocaine. I'll tell you, cocaine. They all take it like this through the nostril, and that can produce sinusitis and bony damage and produce orbital cellulitis. Okay, and family history. Next. No history of thyroid disease. You can run in the family, right?
Yes.
Yeah. What malignancy are you worried about as far as orbit is concerned?
Hemangiomas, lymphangioma.
Pardon?
Breast carcinoma.
Very nice. Breast carcinoma in women and in men?
Prostate, lung cancer.
Lung cancers, isn't it?
Yeah.
Breast cancer. What's the risk actually? If you have a first degree relative, means mother, sister, or daughter has breast cancer, you have double the risk of breast cancer compared to somebody on the street, isn't it? And if two of them has, the risk is threefold. So breast cancer is very important in getting a family history is very relevant, isn't it? In an orbital case. So breast cancer is one, and even CLM, which is the next possible. Possible in men actually. Metastasis to the orbit can happen in CLM, small cell carcinomas of the lung, and there also family history is relevant. Of course, prostate can also produce. Prostate can also produce a secondary into the orbit. Can do all breast cancers produce breast cancer secondary in the orbit produce proptosis?
No.
Can some of them produce enophthalmos?
Bone erosion.
Which type of breast cancer produces enough thalamus than proptosis?
Osteoclast.
What is the type?
Nominal type.
ER negative.
Pardon? Somebody else try.
Sir, ER negative.
There is a variety called atrophic serous carcinoma. Atrophic serous carcinoma of the breast and the stomach are there, but the breast always, when they come into the orbit, they produce severe fibrosis. So instead of proptosis, it produces enough thalamus. Understood? Yeah. Okay. Personal history. Personally, sleep and appetite normal. Sleep is disturbed in which condition?
Hypothyroid.
Even in thyroid eye disease per se, sleep will be disturbed because there will be a lot of congestion in the orbit. It will be a chronic problem. And so, exposure keratopathy once again will disturb the patient's sleep, isn't it? Okay. Now, before we go into general examination, Shifana, what happened to this patient after the 10 days? You told us about the swelling coming, lid swelling coming 10 days back. From there, what happened to the day you examined to the patient? Was the patient admitted in some hospital? Did the patient receive some medications? Or was the patient under your care in these 10 days?
Patient
That part you
actually
didn't tell us.
Patient actually consulted in a local hospital and was referred to RIO. After coming to RIO, he was admitted and was started on systemic antibiotics like injection taxim, injection gentamicin, and metrogyl. Then ENT consultation was done.
No, all this happened in this 10 days, is it?
10 days. Yes, sir.
Before you, from the, you are presenting it 10 days after the patient had this proptosis, right?
Yes, sir.
So in between, the patient was under treatment. So this is actually a patient who is already taking treatment, correct?
Yes.
Yeah. So that part you should actually mention when you present actually. Because I'll be surprised as you see just a mechanical ptosis, not much of congestion and or acute onset. So that doesn't go together. Okay, right. Okay, general examination. Well built and nourished. Weight loss can happen in which orbital diseases?
Malignancies.
Generalized malignancies. Then, which is the most common cause of proptosis in adults?
Thyroiditis, hyperthyroidism.
So you can hyperthyroidism and then tuberculosis. The common disease is tuberculosis. Okay. And then why this clubbing?
Thyroid. Acropathy.
Pardon?
Thyroid
acropathy. Who said that? Thyroid acropathy? Who said that? Very nice, actually. So tell me about thyroid acropathy. What is that actually? What is thyroid acropathy? Shifana, have you heard?
Yes, sir.
Yeah, can you say or we'll ask somebody else to say? Let us give somebody else also a chance. Who can tell me what are the features of thyroid acropathy? What is that? Anybody? Coffee with JP is offered.
Clubbing, swelling.
Yes, very nice. You can get clubbing. Very good. So just
Swelling.
like that, general physical examination is not just a list. Clubbing also has a relevance because if it's a thyroid eye disease, in thyroid eye disease, you can get what is it called? Thyroid acropathy, which includes clubbing, and then there is soft tissue swelling of the hands and feet with periosteal newborn formation. 3 things are there in thyroid acropathy. Okay. What? And then skin, hair, and nail normal. What skin change do you expect in a thyroid disease?
Tibial.
Very good. It's in gravis
mixed edema.
disease. Yeah, in gravis disease you can get pretibial mixed edema. What is the feature of that mixed edema?
Non-pitting.
Non-pitting. Very nice. Bilateral, non-pitting, well demarcated papules. Okay. And what is the skin like in hypothyroidism?
Dry.
Oh, very nice, Stefana. Coarse and dry, isn't it? Very nice. So we have discussed two things related to thyroid eye disease: pretibial mixed edema and thyroid acropatch. Okay. So pretibial mixed edema can occur with orbitopathy in a very high number of patients. Okay. Lymphadenopathy. Why lymphadenopathy? Was next one.
Malignancies.
Very good. Malignancies. Then can thyroid eye disease have lymphadenopathy? Yeah, it can. Thyroid in gravis disease, you can get lymphocytosis, you can get lymph node enlargement, you can get even a large spleen, isn't it? Then you also think in terms of lymphomas, sarcoma, sarcoid and other infiltrative diseases. Vitals. Next slide. Vitals. Very nice. Okay. So in which orbital disease will you get a differential pulse? Shifana? Differential pulse. Differential pressures, IOP we already discussed, isn't it? Looking straight is one. When you are looking up, it goes beyond how many millimeters of mercury to call it? There is it's
More
possible.
than 6. More
5
than 6.
millimeter.
Yeah, 5 or 6 millimeters beyond that means you get that. You think that it is high, isn't it? So what is differential pulse like that? Looking straight, it is 80, and looking up, it is 50. In which orbital condition do we get that? When you are operating on spin, if you are spin surgeon, is doing surgery, block has not come well, you catch on the muscle, extraocular muscle, you look at the monitor, what will you see?
Cardiac.
Ocular
Very nice.
hypotension. Cardiac.
Oculocardiac.
Very nice. It's an oculocardiac reflex. An oculocardiac reflex. What is the afferent and what is the efferent of this reflex, Shifana? Afferent is the ophthalmic and efferent, of course, is always the which can bring the vagus. Yeah,
Vagus.
Very nice. Very good. Okay, and then so fever, you said febrile, but the patient is febrile. What are the orbital diseases where you have fever associated? You said preseptal, you said orbital. You can have an orbital abscess. 3 days, fever is not going. There may be an abscess or a subperiosteal abscess, isn't it? Or it has gone posteriorly into the cavernous sinus. Or there may be a cerebral abscess or a meningitis. All these things may be there. You have to think in terms of that. In the systemic examination, next. Systemic examination, have you mentioned meningeal signs? That is the most important thing, isn't it? In an orbital cellulitis, whether you are seeing for the first time or you are following up a patient with orbital cellulitis, you have to look at this because daily you have to go and see whether this patient under your care is developing meningeal signs, isn't it? Whether there is a spread backwards, isn't it? Correct. Okay. So, ocular examination. Hirschberg's test. Less than 15 degrees, esotropy. Okay. So this particular photograph, whenever you take a photograph for clinical purpose, ensure that both the sides are well illuminated. Here the window is on the right side. So I cannot make a comment on the left side lids actually. You understood, Shivan? So whenever, it is very important. If you look at evaluation of proptosis, you know all the 7 P's of evaluating proptosis that you know. What is the 8th P?
Photograph.
Very nice. The photography is the 8th one, and that has to be done properly. Not only for you, and photography, not only you, the one that you are taking, you can always go back and see how this gentleman looked before the injury, or when he was 5 years, 6 years. Very important in spin, very important in ptosis surgery, ptosis and all. This is very relevant. We call it the FAT scan. FAT scan. It's called family album tomography. Okay, right. Right, Shifana. So I'll assume. So you know better than me regarding the lid color. Was it the color remaining previously also, or this is something new which has happened?
No, previously also it was like
Just the
this.
same. So I'll accept that. Fullness of the superior sulcus was noted, isn't it? So what are the conditions which can produce this fullness of the superior sulcus?
Superior.
So whenever there is an orbital cellulitis, you can get this sort of a fullness. Superior sulcus fullness. In thyroid eye disease, you can get superior sulcus as well as the inferior lid also full, isn't it? Full and edematous. Yeah. Then which
Superior.
have you seen dirophilaria cases in your practice? Parasitic infestation rather. It is there. It's quite common in our part of the country. They all come migrate towards the anterior part of the orbit, superiorly or inferiorly, and then finally they will move around. Sometimes it is seen in the conjunctiva. You see in the newspapers, somebody has taken it out and then they will put it in WhatsApp or put it in the newspaper. It's a dirophilaria spread by mosquitoes only. Okay. And so they can form cyst and be present as a swelling of the upper lid or lower lid. And characteristically, they will also have itching, parasitic infestation, itching may be there. No visible pulsations. Okay. Pulsations are seen in which situations?
Caroticocavernous fistula.
Yes. Anything else?
AV malformation.
That is one of the caroticocavernous fistula is one of the AV mal. Then
Aneurysms of the aneurysms of internal artery. Aneurysms.
Why should it produce? See, pulsation occurs because of 2 reasons. One is if there is a communication between the artery and the vein, and then there is a channel through which blood is flowing at a high speed. That is one. 2 is brain pulsations being transmitted into the orbit, isn't it? Understand? Classically, and the most important is neurofibromatosis. What is wrong in neurofibromatosis which produces this pulse?
Bones get upset.
Yeah, problem of absence of the
Bony
Bone.
which bone is that? Which part of the orbit? The sphenoid. The sphenoid is involved, the greater vein. So that there is a direct communication between the orbital soft tissue and the brain, isn't it? And why should the brain pulsate, Shifana?
CSF.
Why should CSF pulsate? Yeah, because we are in a tight compartment and the arterial pulsations are transmitted to the brain and CSF. That is all. It is not that the brain has a pulsation of its own. It's only because we have the arterial pulsation which are transmitted to the brain and that gets transmitted down here. So how will you appreciate fine pulsation in the OPD?
During explanation tonometry.
Very nice. I'm so glad. Applanation,
Myers.
tonometry, you will see the Myers, isn't it? Moving to and fro like that. And two, of course, when you use a Hertel's exophthalmometer, you can stand in the front and actually see the eye pulsating, isn't it? So which condition will you get a deep superior sulcus, Shifana? A deep superior sulcus. If the volume of tissue in the orbit is reduced, like if you have a blowout fracture, the orbit has become big, the globe has sunk down. So that then you can get a superior
Deep superior.
sulcus, deep sulcus. Which drug can produce that sort of a sulcus? Everything fat, everything is absorbed. Very good. I am very happy, Shifana. Very nice you said that answer. Very good. Then, so if the lids were ecchymotic, ecchymosis means what?
Blackish discoloration.
What is the difference between erythema and ecchymosis? What is the difference in erythema and ecchymosis?
Erythema is a sign of inflammation.
Where?
Ecchymosis due to trauma, blood.
Due to any reason, some inflammation, vasodilation, dilated vessels and fluid only. Whereas ecchymosis is always blood outside the blood vessel, isn't it? Into the soft tissue. That is ecchymosis. Bilateral, if the patient has bilateral ecchymosis, if this patient has bilateral ecchymosis of the lids, what are the conditions which can produce bilateral ecchymosis of the lids? I thought of that only because I saw this hyperpigmentation. Right? What is that sign called? Yeah, very good.
Nice.
Yeah, you just said that. What is that?
Raccoonitis.
Very nice. Raccoon eye or Panta. We call it Panta sign also, isn't it? But those things are all not relevant. Bilateral ecchymotic lids. What are the conditions in a small child? What secondary can produce?
Retinoblastoma.
No, it's a neuroblastoma.
Neuroblastoma.
Bilateral neuroblastoma, isn't it? Then, of course, other conditions can also produce, like leukemia also can have bilateral. And, of course, child abuse is one possibility. You should always think in terms of you have to get a good family history. And post-trauma, you have to remember that there can be fracture base of skull. If you are going to the casualty, say post-RTA, you are seeing bilateral ecchymotic lids, always suspect that there is a fracture of the base of skull. You ask him whether there is some fluid coming through the nose. Okay, right. So next. No, okay. No change noted during Valsalva maneuver that you have said the previous slide. Which condition you get change?
Orbital varix.
Varices, isn't it? Orbital varix. Okay. No thyroid eye signs. Okay, I will not have a detailed discussion about thyroid eye signs today. We will think of more of inflammatory condition, infective condition. Now, which is the pathognomonic sign of thyroid eye disease? One sign.
Lid retraction.
Very nice. Lid retraction. Lid retraction is pathognomonic of thyroid eye disease. Okay. Always remember that. One sign if you are asked, it is lid retraction. Other conditions which produce lid retraction are definitely there, but they are all far and few. And there may be associated other things to tell you, but if it is an isolated, lid retraction is a hallmark, pathognomonic sign of thyroid eye disease. Understood? Right. We'll go to the next slide. Now, I am telling you, Shifana, from these photographs. These photographs. the central one, primary gaze position, the central position. I am arguing with you that this patient is having right eye proptosis.
It
So how
may
will you
be
refute?
it may be due to the like left eye ptosis.
Very nice. So this is pseudo. So
Proptosis.
whenever you measure all that, how will you make it normal?
Can elevate the ptotic lid.
Correct. You can elevate the cortical or just keep it closed also for some, pad it for some time also. So then this is because of which law is that?
Herring's law.
Herring's law of equal
Herring's law.
innervation.
Very nice. I'm so happy, Shafana. Tell me a few other conditions which can produce pseudoproptosis.
High myopia, large globe as in high myopia,
Yes.
congenital ophthalmos,
Yes.
condylateral in ophthalmos, condylateral
Yes.
ptosis, ipsilateral lid retraction.
Very good. I'm so happy you said that. Now, left eye, you said there is limitation of movement, no? Both in dextro elevation and levo elevation, isn't it? Correct.
Yes, sir.
There is a restriction there, isn't it?
Yes, sir.
Up and in and up and out are restricted. Mild restriction. Correct. Yeah. So was there any diplopia with that?
No, not when I was examining.
Did you do a diplopia charting? Try doing a diplopia charting, putting red and green.
No.
You didn't try. That you should try. So whenever you have an orbital case, when you have some amount of muscle involvement, always do a diplopia chart, which is very important, not only for a diagnosis, it's also important when you follow up the patient. You are treating this patient and you want to know how this patient is improving after 7 days. Are the two images coming closer, isn't it? So that you have to definitely do. And also, when you are doing this extraocular movements, you should ask the patient whether he is feeling a restriction when he is looking up. For example, in a thyroid patient, when he is looking up, there can be he may feel a restriction. In a blowout fracture of the floor, this is a post-trauma patient, post-trauma. There can be a blowout of the floor. When he is looking up, he may feel a restriction, not only diplopia, but also restriction. So that you have to ask. Okay, palpation and all will leave? No. Okay. Next slide. Okay, fine. Next slide. These are all you have done well. Yeah. No enlarged regional lymph node. Which are the regional lymph nodes, Shifana, you are thinking about?
Preauricular, submandibular, submental, anterior cervical.
Superficial cervical and deep cervical. These are the ones. Yeah. Tell me where the lids drain. The eyelids and the conjunctiva.
Medial 2/3 of the upper lid and medial 1/3 of
No. Tell again.
Upper lid in the medial 2/3 and
lateral 2/3. Lateral 2/3
and lower lid in the lateral 1/3
drain into
preauricular.
Very nice. So the rest is draining into the submandibular. Yeah, always remember that. Okay. So whenever there is a lesion in that area, always look for that node. Lymphatic drainage. Okay. Resistance to retropulsion is there in which conditions?
Thyroid eye disease.
Very nice. Thyroid eye disease, and then
solid tumors.
Also solid tumors. Solid tumors usually produces resistance to retropulsion, or an acute hemorrhage, for example, can produce tense globe, isn't it? Resistance to retropulsion. So we have palpation, inspection, palpation. Is there any percussion that you do in orbital disease? We don't usually. We usually press, but we can always do percussion of the sinuses to see whether there is any sinus tenderness. Generally, most of the people just press, or you can tap on the sinuses. Okay. And auscultation, okay, that we said. So measurement. Hertels. So what are the ways you can measure?
Clinical methods, radiographic methods, clinical methods, Hertels, exophthalmometry, Lutz, exophthalmometry.
Before that, yeah, there is a qualitative evaluation. Just is there or not, and which eye is that part. That is done by.
Nafziger's view
And
and
very nice. I'm glad that you know that. Okay, we'll come to Hertels. Yeah, Hertels.
Hertels, Lutz, Nagels,
Nugels.
Nugels,
These are the exophthalmometers. Okay. You are sitting in a primary health center, Shifana. You don't have Hertels. You have don't.
rulers, two ruler.
Even a
Using a
single roller is enough to
single ruler.
see primary proptosis in primary position. And the rest that we'll go to. How will you do in Hertels exophthalmometer? How do you do? Did you do in this case? You did?
Yes. Yes.
Yeah, tell us. Let everyone
stand-
hear, the PGs here. How you do?
Stand in front of the patient at the eye level of the patient. Ask the patient to look
No. Patient is sitting or standing?
straight ahead.
No.
The
Tifana,
sitting.
patient is sitting. So you also should be sitting only.
Yes, sir.
Isn't it?
Yes, sir.
It should be a well-lit room or a dim-lit room?
Well lit look.
Well-lit room. Yeah. Then you should
at
be at
the,
the same eye level, correct?
eye level of the patient.
Right. Yeah.
Patient should be looking straight ahead.
Very nice. The patient should be looking straight forwards. Okay.
Place the
The nose part of the
part of the
rim, the
exophthalmometer
nose.
at the lateral orbital rim, and keep the base at a fixed level and look through the mirror on the side and measure till the apex of the cornea.
Very nice. Two things I want to tell you is, whenever you are telling about a clinical test, any clinical test for RAPD or you are looking for Hertels, explain to the patient first. I will explain that I am going to do this and that. And before you put that hard metal thing onto the lateral orbital rim, always take your fingers, touch, see whether the patient is wincing. If it is an painful condition, the patient may not allow, isn't it? Understood? And always one eye to be closed, the other eye to look towards your left. If you are checking the right eye of that patient, you have to ask the patient to look at your left eye. And you should close your right eye. Okay? What are the errors that can come when you are doing this?
Parallax error.
Errors. What error can come in Hertels? What is the problem actually with Hertels?
Parallax error if you are looking from a different angle.
Parallax error. Very nice. So how will you avoid parallax error in Hertels?
Sit at the same level, eye level of the examiner have to be at the same eye level.
No. There are two red lines. Have you seen the red lines in the Hertels?
Red line and black line.
That is a vernier. It's a vernier. So that red lines have to coincide and that should be opposite. I mean over one another. That will avoid parallax. Then you take your measurement. Okay. Two is when you are keeping the Hertels, ensure that it is horizontal. We don't have any indirect evidence to tell you or a direct evidence to tell you that this you are measuring the horizontal, keeping it horizontal. Whereas in a Nugels exophthalmometer, they also have a spirit level in that. You know spirit level? Which people, the masons use while making building walls. They'll keep and see whether it is horizontal, exactly horizontal. It will be a small bubble there and two marks within which it has to be there. Similarly, there is a bubble spirit marker in the center of a Nugels exophthalmometer so that you know whether you are keeping it slanting or straight. This is very important that you need to have it exactly horizontal. Okay. So that is one error that you can induce. Okay. Right. So you got how much is that? 3 mm of
3 mm difference.
Yeah. Then you have written 2 mm horizontal and vertical dystopia. So I am not getting any information from this. I only know that it is not looking forward. You got it.
Down.
Where did it go? That you have said.
Down.
Understood?
Mm.
Yeah. Whether it has moved medially, whether it has gone laterally, up or down. That part. Now you are telling me, and from your history, from the previous statement, we know that it has moved down and in,
Down
isn't it?
in. Yes.
When you are measuring dystopia,
Mm.
yeah, when you are measuring dystopia,
Mm.
how do you proceed? How do you measure the dystopia? Horizontal dystopia, for example. Tell me.
Horizontal dystopia using a simple ruler from the midpoint of the root of the nose till the either the nasal nimbus or the pupillary reflex.
Yeah. And vertical?
Placing a vertical, place a ruler in the superior orbital margin, and from there, vertical distance from the first ruler to the pupillary light reflex on either side.
Very good. What is the most important aspect that you should have in mind when you are measuring this? Always have the eye in primary position. Because if you are measuring, if this eyeball has moved to right side, for here, to the temporal side, the eye has moved. So you are measuring from the root of the nose to the eyeball, to the limbus. But if the eye has an exotropia, you will measure more. You got the point? So each eye, whenever you are measuring, that eye should be in primary position. So always remember, these two are different. Tropia is different, dystopia is different. So whenever you are measuring dystopia, it is important that that particular eye is looking straight forward. Got it?
Yes.
Yeah. And can you use a CT scan to measure that? You must be knowing.
A Hillel and Trochel method.
Oh, very nice. You know that? Very nice. Yeah. Which cut will you take?
Axial CT at
Yes.
mid-level.
What is
Mid-level
mid-level?
Equator is this. Where
Pardon?
equator can be seen.
No. Where the lens and the optic disc, no, that cut you should be there. Where both the lens and the optic disc, that is the cut that you should take. Axial scan, you are absolutely correct. And then you draw this
Indozygomatic line.
Indozygomatic. So you know that. Drop to perpendicular from the
Indozygomatic line to the posterior surface of this cornea.
and what to the corneal apex, isn't it? To the corneal apex. Can we measure backwards also?
Yes, sir. To the optic sclera.
Very nice. To the sclera. Will it be reduced in proptosis or increased in proptosis?
Reduced.
Very nice. I'm so glad you said that. So ptosis evaluation. So what do you think can be the cause of a ptosis in an orbital disease? Yeah. What are the various methods by which we can have a ptosis?
Can be mechanical ptosis due to edema, swelling.
Very nice. The edema of some standing, lot of edema for some standing can act as a weight and pull down the lid, isn't it? Yeah. Then
nerve involvement.
Nerve involvement because of compression or even direct injury, and muscle injury, isn't it? Muscle injury or muscle inflammation, making it functionally less effective, isn't it? So all these can produce
ptosis.
Ptosis. Which muscle is involved in ptosis, madam?
Levator palpebra's.
Very nice. Very nice. Supplied by?
Third nerve.
Very nice. Very good. Okay. Next one. Let us come to vision. This is, I think we always used to call this visual acuity. Is it? Yeah. So always write that when you are going for exam. Because if you don't write it properly, then they will ask you what define visual acuity. You have so many other things to remember other than defining visual acuity. Okay. And then they'll ask you 6 by 60. What do you mean by visual acuity of 6 by 60? So then you are diverting to an area where you are not that sure. So always write all these things. Don't get into attract questions which you do not know. Okay. Okay, field of vision. In a thyroid eye disease, which field is usually first affected? Usually the inferior field. Okay, the inferior field is usually affected. Okay. So that is a big problem because navigation, you need the inferior field. Understand? For navigation, if you want walking around, you need that inferior field is very important, isn't it? Okay, we'll come to the next slide. Cornea have written normal, transparency is okay, corneal sensation is normal. What else will you look for in the cornea in this patient?
Signs of exposure keratitis.
Very nice. You can have exposure keratitis, isn't it? Shifana?
Yes, sir.
Can be. So you want to put a little fluorescent and see whether there is any stain being taken up.
Yes.
Why should there be exposure keratitis? The eye is kept close by the ptosis, no? See, the eye is kept close by the ptosis. It's not complete. That's the answer. It's not complete. And blink is reduced. In whenever there is a heavy weight hanging there, blink rate is very much reduced. So, and the lower half, the lower 1/3 will be affected. And so you should always put in a bit of fluorescent and see whether it is taking up stain. Because in any proptosis patient, the most important worry for us is exposure keratopathy on one side and behind the optic nerve, isn't it? These are the main issues we are concerned with, isn't it? Anterior chamber is normal, isn't it?
Yes.
Yeah, in which orbital disease will we have this flare and cells? Tell me one orbital inflammation where you can get, it has to be an inflammation, right? Yeah.
Non-specific.
Very good. Yeah, very good. And which age group do you see that? Children. Children. So children can have bilateral non-specific orbital inflammatory disease, bilateral, and that may be associated with anterior uveitis. Got it? So in a child. And of course, sarcoidosis is another situation where you can have orbital involvement and you know how it is, you can get adenocyclitis, isn't it? Next one. So here you have told about the differential tonometry. Okay. So how did you check this IOP in upgaze? Was it possible? Here's only -1. So how did you?
Only -1 restriction. So by keeping the chin down and elevating the lid.
Chin down or not on the chin rest. Don't keep the chin rest, chin on the chin rest. Keep like this, bend forwards and open up. Alternatively, you can use what? Tonometer with a smaller footprint. Which one has a small footprint? What do you use, which you have in your hospital?
Tono pen.
Very nice. A tono pen you can use, or a rebound tonometer you can use, isn't it? Okay. Next slide. Slit lamp examination. Okay, fine. Normal size disc. What is a normal size disc? What is normal? What is normal size? Who is PG? PG. I did not see the faces of other PGs. So it is 1.88 vertical and 1.77 horizontal. That is the average. And smaller ones are small and larger ones are large. That is all. And with your 90D examination you have done, isn't it?
Yes.
Correct. So tell me, how will you measure this height, the width and height of the optic disc?
Using the changing the gratitude.
Very good. You are equal in the slit lamp, right? And then, so I'm getting 1.1. Then?
Small.
Then? No, you have to multiply actually. When you are using a 90 diopter, always remember that when you are using a 90 diopter lens, you have to multiply with 1.3 something, I'm not very sure. Find out that. And if it is a
1.3, sir.
Very good, 1.3 something is there. And if it is a 78 diopter lens, It is
1.1.
1.18. Yeah. Okay. Then. What is the magnification? It's a direct ophthalmoscope. Shifana, direct ophthalmoscope. Magnification.
15 times.
Very nice. 15 times. 15. That is 60 is the total dioptric power of the eye, isn't it? Divided by 4 is 15. Always remember like that. 15, 1, 5. Isn't it? Direct or inverted image you get in direct ophthalmoscopy?
Direct image.
Direct.
Direct image.
Are you using direct ophthalmoscope these days? No, you don't. Okay. And indirect, what is the magnification that you get? Indirect?
5 times. 5 times.
5, 2 to 5,
times.
depending upon the lens that you use, isn't it?
Yes.
Yes.
Fine. Very nice. Okay. So here we have come to that summary and all. Okay, we'll finish that. Okay. So you have told us the various differential diagnosis. And after all the discussions, we know that it is most probably something to do with the orbit and mostly infective, isn't it? Even though you have got so many other differential diagnoses, with plus and minus, I don't think we have time for all that. So what are the points in favor of an orbital cellulitis, madam? Tell me in this patient.
Acute onset of pain and swelling around the eye associated with fever.
Very good. Then?
Extraocular motility restriction.
Yeah, with proptosis.
With proptosis and extraocular motility restriction.
Right. So what is the difference between preseptal and orbital cellulitis? Which structure demarcates this?
Orbital septum.
The orbital
Posterior.
septum. Okay.
Septum
And where is the inferior orbital septum attached?
Inferior tarsal plate.
Inferior. Which part of the inferior tarsal plate is it attached?
4 millimeter above the upper.
No, Anjana. It is to the margin of the inferior tarsal plate. The inferior orbital septum starts off from the orbital rim and comes up and is attached to the inferior margin of the inferior tarsal plate. And what about the superior orbital septum?
Fuses
It starts off from?
Aponeuros of the levator palpebral.
It starts off from? What is the structure at the anterior orbital margin called? Arcus marginalis. Arcus marginalis. So from there, this fibrous tissue sheet comes down and inserts where?
Levator. Aponeuros.
Very good. On the aponeuros of the levator, just a few millimeters above the tarsal plate, isn't it? And why is that? Why is it not going to the tarsal plate? Because the levator is still going forward and attaching 2 to 3 millimeters below the upper border of the upper tarsal plate. Understand? So this is above that, isn't it? So if you are cutting the lid through and through, from outside to inside, say through the lid crease, for example, lid crease, what are the structures you will cut, Shifana?
Skin, orbicularis.
Hello?
Sir.
Yeah.
Skin, orbicularis oculi, orbital septum, then tarsal plate.
Above.
Pattern.
We'll have the orbital, we have the skin, the orbicularis, then we have the orbital septum. You cut open the orbital septum, what will come out? What will come out? Fat. The fat will come out. That is a pre-aponeurotic fat. And below that we have
Tarsal plate.
the levator palpebrae, the aponeurosis of LPS, isn't it? The aponeurosis of LPS. And below that?
Tarsal plate.
No, this is above the tarsal plate. What else is there above the tarsal plate? Under the LPS? Then there are only 2 more things there, no? Which is the
Mullus
muscle, the mullus muscle, and below that is the conjunctiva, isn't it? The bulbar conjunctiva, correct?
Yes,
Yeah.
sir.
So let us. So we have talked about orbital cellulitis. So when you are following up orbital cellulitis, how will you know that it has gone into the cavernous sinus?
From symptoms, signs of patient can
Persistent
present
fever, isn't it? Persistent fever will be there.
headache.
What about
signs
headache?
of headache.
Yes. Consciousness. There may be
Altered
altered consciousness.
mental status.
Chemosis will increase
Mm.
because there will be some block of the venous drainage, isn't it? So chemosis will increase. And can it become bilateral cavernous sinus thrombosis?
Yes.
Yeah. So when you have an infection in one eye and it is orbital cellulitis, you are following a patient is in the ward and you are seeing that the other eye is getting involved, suddenly it should alert you that it has gone posteriorly into the cavernous sinus. And of course, if you have bilateral ecchymosis, that also helps. If there is an increased involvement of extraocular muscle also, that is going in favor of cavernous sinus thrombosis. Okay. Okay, treatment part. So you have, how will you manage?
First, investigations can do a routine blood investigations.
Yes. What do you see in CBC, complete blood count? What do you see in an orbital cellulitis?
Elevated total count.
And
Raised ESR.
what type of cells will be increased in acute bacterial neutrophilic leukocytosis? Yeah. Then what else?
Raised inflammatory markers like ESR, CRP.
CRP. Yes. Then
imaging can be done.
yes, imaging has to be done. Which is ideal imaging?
CT scan of orbit.
MRI.
It is always CT. It is always CT first in the orbit, isn't it? CT first.
Then
and with contrast or without contrast?
Without contrast, plain CT.
Yeah, with contrast is when you suspect an abscess. That is brought out much better in a CT with contrast. And any cultures you will send?
Blood culture can be sent.
Then?
Like in case of recurrent sinusitis,
Nasal swab you can take, throat swab you can take, conjunctival swab you can take, isn't it? And please remember that most of these will come negative, including the blood culture. Okay. Which are the most common organisms involved in orbital cellulitis, madam?
Staphylococcus aureus, Streptococcus pneumoniae.
Right. And very rarely you can get Haemophilus influenza. Previously, that was the most common one in children, isn't it? Now, because of vaccination and all, it is down, but still there. Always remember that. Then you can also have anaerobes and pseudomonas, which are very rare, isn't it? So, what are the drugs that you will use? Tell me.
Broad spectrum antibiotics.
So, you initially, it's like a big masala of antibiotics and try to kill from all sides, isn't it? Because we cannot wait. We cannot do a targeted treatment because we do not know the organism, isn't it? But we know from various studies previously that before 9 years of age, it is usually a single bacteria, and anaerobic infections are rare, almost nil below 9 years of age. So if it is below 9 years of age and above 9 years of age, the treatment will be different. So what is the primary drug used?
Broad spectrum antibiotics like third generation cephalosporins.
Very nice. And there will be a combination. What did you use? That only you can say, no problem.
Cefotaxime.
Cefotaxime, very good. Yeah, cefotaxime.
Gentamicin, aminoglycoside, gentamicin, and anaerobic coverage with metronidazole.
Very nice. So generally, previously, while we were relatively young, we used to use CP Genda because that was very cheap. Crystalline penicillin is very cheap, and Genda, isn't it? And then we had all these cephalosporins coming in, and then we slowly changed. What is the mechanism of action of gentamicin, Shifana?
Ribosome.
Yes, very good. Which is that? Which ribosome is affected? 30S. Very good. 30S. And what about the cephalosporins?
Cell.
Very good. Cell wall synthesis. I'm so happy of saying all these things. So happy. Yeah. And then, so we can have a combination of CP Genda previously. And if not, we can use a combination of Genda with Cephalosporin, because Cephalosporin is slightly less cheap. Cephalosporin, once a cephalosporin, it will also affect cell wall synthesis of the bacteria. Or you can use a combination of vancomycin with cefotaxime or ceftriaxone, a combination of vancomycin. How does vancomycin act? Cell wall synthesis. Remember that. Vancomycin also inhibits cell wall synthesis. And vancomycin is especially useful in cases of
MRSA.
MRSA. Can MRSA be there in the community now?
Yes.
It is there.
Yes.
It is not hospital based anymore. I think we had one study from P.J. Chandigarh, where they had 27% patients with orbital cellulitis with proven MRSA. Okay? Okay. So if the patient is allergic to penicillin or cephalosporin, if somebody is allergic to penicillin, they can be allergic to cephalosporin. Then what will you use combination? You can use vancomycin plus fluoroquinolones. Okay, vancomycin with fluoroquinolone. Which are the fluoroquinolones you know?
Ciprofloxacin.
Yeah, very nice. Very nice. Mechanism of action is DNA gyrase. You will remember that.
DNA gyrase.
Yeah, always remember that. Side effect is? Side effect, why we are worried? Because here you have to give it for a long period of time, isn't it? Rupture tendon, Achilles tendon rupture. Generally, it produces muscle pain, fibromyalgia, higher doses, longer period of time can even have that major side effect. Okay. If you have a child over 9 years or in an adult, always you can add metrogel because there may be an anaerobic infection, isn't it?
Yes.
What about in neonates? What additional procedure will you do in neonates? In an orbital cellulitis or even in a preseptal cellulitis? An LP is indicated, an LP. Okay, even if there is only evidence of orbital cellulitis or preseptal, this is indicated, and an LP is indicated. And anything you will pour into the nose, madam, in this patient? You want to have an ENT consultation?
Yes, sir.
Isn't it? You have to use nasal decongestant, isn't it? So you have to concurrently treat the sinusitis, isn't it? Yeah. How long will you give antibiotics?
For 7 days.
Yeah, generally all these Western books, they will say pure orbital cellulitis you give for 3 days and then change over to oral antibiotics if it is responding well. But then generally we give it for 5 to 7 days and then continue oral for another 10 days or 2 weeks. That is what we give, isn't it?
Yes.
Okay. Then, when will you drain a subperiosteal abscess? Here the possibility of a hematoma in the orbit, and because it is the upward movement is restricted and the eyeball has been pushed down, the possibility of a subperiosteal abscess which has got infected, subperiosteal hematoma which has got infected is there, isn't it?
Yes. Yes.
Yeah. So how will you, when will you drain a subperiosteal abscess?
If it is causing compressive optic neuropathy. Yes,
very good.
Proptosis causing exposure keratitis.
Yes. If the child is 9 years plus, over 9 years, the child is 9 years plus, and if it is not located on the medial side, close to the ethmoid, the only situation where we leave behind a subperiosteal abscess is a small abscess on the medial wall, close to the ethmoids. In a child who is less than 9 years of age, then you can leave it, you can treat it medically, it may get absorbed. Got the point? Because that wall is porous, is open, isn't it? Either side it is porous, so it may get absorbed over time. Okay. Now, if there is a blowout fracture, now this is my last question. You have done so well, that is why this question has come. If there is a blow in this patient, if there is a blowout fracture of the floor, how will you manage a blowout fracture?
If
You are sitting in the casualty, You have got a patient with blowout fracture of the floor, proved on CT.
If the patient is not complaining of any diplopia, can observe,
Who
can
told you
be
that?
conservative.
What is the traditional management of a blowout fracture? Recently, there was a controversy about this, about a blowout fracture. Everybody was talking about blowout fracture. I do not know. Everyone was putting their own opinions and all. But what actually is the status of a blowout fracture management now?
Plate is placed.
First of all, let me tell you, 99% of patients with blowout fractures who has diplopia, you wait for 6 months, the diplopia will disappear. It has been proved. Okay? Previously, I was taught that you should operate within 14 days. Within 14 days. You don't operate in the first week because of the edema and proptosis and also you operate within 14 days, which is not true. From what insight we have gathered over years, now management of blowout fracture is wait for 6 months because almost nearly 100% of patients with diplopia, the diplopia disappears. Okay? Got it?
Yes, sir.
So diplopia is one problem in blowout fracture. 2 is anophthalmos. Isn't it? That's another issue for the patient. 50% of patients are not bothered about their anophthalmos. Only the surgeon is worried. They will measure with exophthalmometry and find out this eye has gone in by 2 millimeters. I should operate. No. And many times with time, sometimes the fat which has gone into the maxillary antrum can come back into the orbit over time as it heals. So it may not be very obvious. So don't go in. And why there was a lot of rush of operating within 14 days? The results will be good if it is operated within 14 days was the teaching, which is wrong. Because now we have surgeons who are well trained in that field. So who can give excellent results. So even after 6 months, 1 year or 2 years, there is no problem because you can get equally good results as that we get when you have operated within 14 days. So, whenever you are sitting in a casualty, you see a blowout fracture, do not jump into operating on a blowout fracture immediately unless there are 2 situations where you operate immediately. What are they?
Children.
In children with? Very nice. Pardon? Trapdoor fracture where the muscle or the sheath is entrapped and what happens to the child? What is web of white-eyed blowout fracture? White is white. Yeah.
Cardiac.
Oculocardiac reflex we are talking now. The child will say nausea, vomiting, becomes unconscious, bradycardia, falling down. That is an emergency. That's the only situation where you need to do an emergency repair of a blowout fracture. Okay, the only one. And second, of course, if the muscle belly is trapped in a trapdoor fracture, belly. Well, why you have to do that immediately?
5.
Yeah, because if blowout can have 3 things there. The muscle may be inside, the sheath may be inside, or the fat may be inside. Fat is there means you are not bothered. Sheath is inside, we are not bothered. But if the muscle is inside, that can undergo necrosis because blood flow is cut off, then can. So these are the only situations. Let me repeat that 99% patients with blowout fractures need not be operated. Pure blowout fractures. If there is facial bone fractures, then along with that then the maxillofacial surgeon can operate. But otherwise, this can be delayed. That is the current understanding of orbital blowout fractures. Okay. With that, let us stop. Dr. Shifana, you presented so well. I'm so glad. Someday I'm looking forward to having a cup of tea with you, Dr. Shifana. Anybody else in the crowd can ask her questions or put in their chip in with their response. Anybody has any doubts? Right, Dr. Elizabeth, can you conclude?
Yes, sir, we can conclude. Thank you, sir. Thank you, sir, for your great case discussion. And thank you, Shifana, for your good case presentation. And it was very exciting and very amazing. Thank you. Okay.
Thank you.
Anyway, happy
Thank you.
Onam to all.
Happy
We'll
Onam to all
see.
of you. Yeah. Yeah.
And
Thank you.
we'll see in the next month only. So
Yeah.
happy Onam once again.
Thank you so much. Yeah.
Bye. Bye.
Thank you.
Thank you.